Clearly, we made a huge stride by taking the initiative to combine two immunotherapies. Clearly, Ipilimumab has a more dynamic toxicity profile than Nivolumab or the PD-1 inhibitors. And so we treaded very lightly when we combined the two, hoping that we'd be able to give them safely. And the answer is that yes, we can. We had to dose adjust the dose of Nivolumab when we gave it in combination with the Ipilimumab. And even by dose adjusting, we ran into a clear toxicity management, I don't want to say problem, but giving the two drugs together, even at a reduced dose of Nivolumab, gave at least 50 to 60% of patients toxicity that we needed to manage. Most of those toxicities did not preclude us from going on and giving more cycles of therapy. However, there were a good number of patients who did have to come off study right in the beginning when we were giving dual therapies because of toxicity. The very interesting thing about that is even though you manage the toxicities and patients may never have been able to get any more combination therapy, many of those patients went on to respond and have nice durable responses. So many of us feel very comfortable that if a patient has toxicity and they've gotten at least 50% of their what we call induction or the combination, that they may go on to have that prolonged durable response and not have to be treated again. Those toxicities include rash, itching, diarrhea. What we were not, I think, prepared to see was an early onset of endocrinopathies, which normally occur when you treat patients with Ipilimumab somewhere about 16 to 24 weeks after therapy. The endocrinopathies that at least we've seen have occurred much, much sooner at about 6 to 8 weeks. So, you have to be more cognizant and prepared for that.